Okay. All right. Good afternoon, everyone, and thank you all for joining us for today's A Month of Service presentation of Health Insurance One-on-One. What is it that you need to know? My name is Nia Murray. I am Programs Coordinator with Neighborhood Recovery Community Development Corporation, and we are one of the partners in the A Month of Service collaborations. Also included is the City of Houston's Department of Neighborhoods, and joining us today is Ms. Myra Hippolyte. Also included in the partnership is the Houston Bar Association, and our facilitating presenter today is Mr. Garen Raymond with One Digital on behalf of the Houston Bar Association. Also included is Lone Star Legal Aid, the Earl Carl Institute, Houston Volunteer Lawyers, Harris County Appraisal District, and Harris County Tax Assessor and Collector's Office. And collectively, we make up A Month of Service. And basically what A Month of Service is, again, is a collaboration of these 8 different organizations that come together and offer a variety of workshops relative to asset building, asset protection, maintaining of generational wealth, and community empowerment. And this being one of the presentations is part of our community empowerment series. We know that there's a lot of folks in a lot of underserved communities that don't have access to a lot of information and resources, have questions about a lot of things, don't know where to go, what to do, where to start. So we wanted to make sure that we created a larger impact and decided to come together so that we can get this information out to as much people as we possibly can, especially considering we all pretty much service the same community and have the same mission and same goal in mind. So, but with health insurance being one of a big hot topic issue, we know that a lot of folks have questions about health insurance. Does it actually cover? How do you choose the plans, and the services that you get, and what's provided? There's so many questions, so many unknowns, and so much cost involved, especially during the time of COVID that we had gone through, and people not having adequate coverage, and not knowing where to go for different services and things. So we wanted to make sure that we had a professional here to give you guys firsthand information on what it is that you needed to know about the basics of health insurance and what it is that you need to know. So we are wanted to let you guys know that information that we do present here today is for informational purposes only. It's not to be construed as advice. Typically, we have legal workshops, so we wanted to advise people that this is not a personal advice, but just for information only. However, if you do find yourself in need of any civil legal matter or anything of that nature, then we do encourage you to reach out to our legal service partners for more information and to actually apply for their service. In addition to that, I wanted to let you know that we are broadcasting live on our social media platform at Amos Houston TX, so please follow us. And also recording the session. So we would like for you guys to be as interactive as you possibly can. Please feel free to ask whatever questions that you like, but we try to ask you to keep them as general as you possibly can and not give any personal detail information as it is being recorded and broadcast live. We don't want all of your detailed information kind of getting out there for everybody to have access to. So with that being said, please feel free to type whatever questions that you have into the chat. And if you're joining us on Facebook, please feel free to type them into the comment section, and we will go over those at the end of the presentation, as well as, you guys have the opportunity to unmute yourself if you'd like to comment and kind of ask questions directly of Mr. Raymond at the end of the presentation. So with that being said, we're going to go ahead and get started. Ms. Myra, would you like to go ahead and introduce yourself?
Thanks, Ms. Nia. Good afternoon, everyone. My name is Myra Hippolyte, and I work with the City of Houston Department of Neighborhoods under the direction of Division Manager Paul Green. On behalf of Mayor Sylvester Turner and Director Takasha Francis, we want to welcome you to the Month of Service program. This collaboration is all about giving back free information to the Houston, Harris County, and the state of Texas community. Guys, we just want to let you know that you're not alone whenever you're going through a stressor in your life or a disaster. Because you know what, a lot of times stressors are not disasters. So little things that we need assistance in making decisions, that's what we're all about, making sure that everyone has all the free information they need to make the right decision. Know that you're not alone. We're here as a team of partners, to be able to give you as much information as we can. And guess what? Nia and I are not the professionals, so we've got the experts here that will be able to give you the right information, because Nia and I would love to say we know it all. At least my kids say I know it all, but you know, I know I don't. And so guys, this is amazing, great information. And you know, we have great storytellers giving you information. And there's a big difference between a storyteller and someone that's just a book reader. A storyteller has lived the life, knows the information, and lives the information, and also understands the audience. A book reader is only the one person that sits there and just reads the information and just talks to the audience or at the audience. That's the great part about our amazing presenters. Guys, thank you so much. And I myself am thinking that it's Monday, and sadly it is, well, no, great. Thank God it's Tuesday. So I'm a little bit upside down. So I'm sure a lot of y'all are too. Thanks, everyone. Have a great day.
All right. Mr. Raymond, want to go ahead, unmute yourself and introduce yourself, and we can move right on into your presentation.
Yeah, sure thing. Let me share my screen real quick. And get this up and ready. All good? Okay. Well, good afternoon, everybody. My name is Garen Raymond with One Digital. I've been a health insurance broker here in the Houston area for, it's going on, I think it's about 15 years now. Specializing in helping employers set up their benefits packages, things like that. We've also done some, I also do some individual life insurance, financial planning, things like that. As Nia and Myra said, is that this is going to be strictly informational. We want to touch to you guys as consumers. Everybody's going to be having their open enrollment meetings coming up, or maybe yours is in the middle of the year, and I'm going to speak to that. I'm hopefully going to give you some information and some ideas to help you navigate that open enrollment period, because a lot of people just kind of throw stuff at you, say, figure it all out, and you're on your own. And we're not talking about making small financial decisions. We're talking about decisions that can impact you in the tens or even hundreds of thousands of dollars. And so we'll go through how to make those decisions, what open enrollment actually is, and then how to utilize your plan more throughout the year. And I'll give you some stories. Some of them will be horror stories about some people I've helped in the past and that have had trouble navigating this system, because it's not an easy system, the healthcare system. And as I said, I would get on and try and not get on too many soapboxes here, but the healthcare marketplace is completely different than any other marketplace that you've ever purchased a product from or utilized a product from. It doesn't work the exact same way. There's some major issues with it that I will speak on. But it's always good to make sure that you have at least a good working understanding and framework so that you can better take care of yourself and your family throughout that process, right? And having health insurance, okay? And I will stop as we go through these slides. You're gonna see they're very generic slides. They're very just kind of the idea to get talking points going. And I'll give my feedback and my stories and all that fun stuff, but we'll try and stop in between slides because I think it's important to make sure that everybody's understanding and understanding all the information that we are presenting today, and making sure everybody follows along, because sometimes in insurance, we have a tendency of throwing around words and lingos and things like that not everybody understands. I'm going to try and make it as simple and as easy for you guys as I can possibly make it. It's still insurance at the end of the day. And so it's never always totally easy to navigate, but we're going to try and make it as clear for you as we possibly can. Okay. Having said that, get started here. My presentation wants to work for me. Let's talk about what open enrollment is. So open enrollment, usually for a lot of companies, will fall maybe at the beginning of the year. So January 1st of 2023 is when your open enrollment effective date is started. Most of your producers, most of your insurance agents like myself, I've already started working on some of these 1-1s or working with carriers in the background, all that fun stuff. But the bottom line is no matter when your open enrollment period is that is the time for you to make any plan changes you want to have. Maybe your company that you work for is offering you some new plan designs that you have to think about. But now is the time to bring somebody on the plan, take somebody off the plan. It is however you want to, make it work for you. What I like to say is I like to establish the rules of the game that everybody's playing by here. Here's what I mean by that. So when you have your open enrollment time frame, no matter when it is. Like I said, a lot of people have theirs during fourth quarter. Is that is the time that you can do whatever it is that you want to do, but keeping in mind that whatever decisions you make, for the most part, you are going to be stuck with up until open enrollment next year, right? And I just want to make sure everybody understands how that all works. And so that is not your company being mean or the insurance company or anything like that. It's that a lot of the premiums that come out of your pay come out of your gross pay, not your take-home pay, meaning you're not paying taxes on those premiums. So the federal government, in their infinite wisdom, as you'll hear me say a few times throughout this presentation, is that they say that we will not allow you. What you cannot do is get on the plan, get your surgery, and then halfway through the year say, well, I don't need this anymore, and then drop off the plan, right? It breaks the entire insurance system when you do that. So the only time you can make a change to your whatever you decide to do at open enrollment is if you have what's called a qualifying life event. And a qualifying life event is like maybe you're on in your medical plan and your spouse, you get married and you need to bring your spouse on, or maybe you have a child and you need to bring your child on. Maybe you get divorced and you need to remove your spouse off. That is considered a qualifying life event. And that event will trigger an allowance by the insurance companies for you to make a change throughout the year. So bringing somebody on, maybe you need to take somebody off, but keeping in mind that on that qualifying life event, you only have 30 days from when that event took place. Meaning, so if you lost coverage or somebody has lost coverage, they have 30 days from when that event takes place to notify their company so that they can either make their plan change or do whatever it is they need to do, right? So we talked about if you get married, if you have a child, those are all qualifying life events, obviously. Some more common life events that a lot of people aren't aware of is maybe like right now you're going through your open enrollment period and you're deciding what you're going to do, but your spouse has a different open enrollment period, or they start a new job, right? Maybe they have one in July or August or something like that. If that's the case, it's totally fine. Maybe they have a whole new benefit package that they didn't have before. Anything that is changing what you based your decisions off of whenever you decided to go in and enroll. So it's a completely different set of circumstances, like your spouse has a new plan available to them, or maybe you get divorced or whatever it is, that is considered a qualifying life event where you have 30 days from that event to make that change, okay? Otherwise, for the most part, whatever you've enrolled in, you are for the most part stuck with up until open enrollment next year. So I just always think it's important to start the entire conversation with everybody understanding the gravity of the decisions that they're making there. Okay. Does anybody have any questions as far as open enrollment before I move on? Everybody pretty good. A couple of things to keep in mind is maybe if you're starting a new job as well, is keep in mind is that while you have an open enrollment period, right, that comes up annually, that also when you start a new hire, you might have a waiting period before your benefits kick in. If you have that, it could be 60 days, 30 days, 0 days, whatever it is that you could have that waiting period. So we're only talking about, and it's possible to have, maybe you have a new hire date in, let's say, October, and then your stuff is effective in December, and then you have open enrollment also occurring on January 1st, right? So it's important to understand which dates you have lined up. But most of us, if you've been with a company more than a year or been with a company for more than a few months, if you have benefits available to you, you'll have your open enrollment period whenever that may be, and proper communication should always go out to you in order for you to make those kind of impactful decisions. Another thing to keep in mind whenever you're talking about open enrollment is that when you're picking your plans, if you think you are getting married in the middle of the year, or maybe you're having a child or something like that, the things you got to watch out for is not all carriers facilitate making plan changes in the middle of the year. So sometimes you may want to watch out and make sure you're on a more affordable plan because you're going to have to cover your spouse or a dependent or something like that. What you don't want to do is maybe you're just covering yourself right now. So you're just like, oh, I'll go on the richest plan. Doesn't matter. I'm going to pay a bunch of money in premium for just myself, but it's really not that bad because it's just me. And your employer is probably helping contribute to those premiums, right? But if you try to bring a spouse on or you try to bring a dependent on, sometimes those premiums are doubling or tripling in some cases, right? So you probably wish I had a more economical plan at that point in time. So keep that in mind. I just always think it's important that we understand the gravity of the decisions we're making when we're analyzing our open enrollment. Okay. Any questions on that? Everybody pretty good? All right. So let's keep on going here. Now let's talk about how to save money. And when we talk about how to save money, we're talking about your carrier, networks, right? And this is the most important way for you to save money on your plan. So regardless of the plan that you're on, there's usually a carrier network. And I say usually, this isn't always the case because there's some new products that have come out recently that I'm not going to get into because it'll muddy the waters, but is that usually you have a network associated with your plan, whether that's a PPO or an HMO. Regardless, it is absolutely crucial. And if you don't hear a word I say all day, that is completely fine, but it is absolutely crucial that you stay inside the network. That is the most important way and the best way for you to control costs when it comes to utilizing your health plan. And here's what I mean by that. So when a carrier, if you have a Blue Cross, Humana, Aetna, United Healthcare, doesn't matter the carrier you're with, usually there's a network that they have associated with that plan. And now networks can vary depending on which plan you have, right? Just because you have United Healthcare doesn't mean you have the same network if you're on a PPO plan versus an HMO plan. So what you're allowed to do is that you always want to stay inside that network because that carrier has now negotiated with these doctors. These doctors have agreed to join that network and they are contracted to not charge you any extra than that negotiated fee between the insurance company and the doctor. And if they charge you more than that fee, then that is illegal and they're not allowed to do that. So it gives you protection by staying inside the network. When you go outside of that network, that doctor can charge you whatever they want. The insurance company is only going to agree to what they think is fair. And then you're going to be on the hook for the rest of it, right? Which is not going to be a good thing. And I don't mind telling you guys, I have seen medical bills that cost tens of thousands of dollars. I've seen premature babies born that cost $1 million bill. I mean, $1 million. And it over the last 10 years, it's even exacerbated it even more. And you can see, I see prescription drugs that cost $300,000 now. I see surgeries done that cost hundreds of thousands of dollars now. So when I say that you're on the hook, I'm not saying that if you just if you go outside the network that you're just completely on your own. You are completely on your own. You will have to pay all that money and it will be held against you from a crediting standpoint. So that's why it's so crucial to have that health insurance, but more importantly, that's why it's so crucial to stay inside the network. I'll tell you guys a quick story and how this, I have a feeling a lot of people might be able to relate to this. So the story happens to my dad. He's on a health insurance plan. He has back surgery, doctors inside the network. Everything works out just fine, right? Ends up paying his deductible. It's subject to his deductible, which we'll talk about more in a little bit, but everything works out okay. He has to have a different surgery, okay, or same surgery on a different portion of his back, same doctor, same insurance plan, all that a few years later. So he goes in and gets consultation. It's all working the exact same way. And then a few days before his surgery, the doctor says, hey, we're not going to do the surgery at the same spot. I'm going to send you down to this new location I got in Clear Lake or something like that. And I already knew when my dad was talking to me that this was a massive red flag. And so what happened is the doctors in the network, the insurance companies are the same, all that's good. The surgical facility the doctor sent my dad to, that he had to go to, that was outside of the network, was owned by the doctor. Okay. And so he gets a bill, a balance bill, which we're going to talk about more in a little bit. He gets a balance bill from that surgical facility. The doctor was in the network. All that worked out okay. But the facility that he performed the surgery at was not inside the network. I believe my dad got an $8,000, if not more, balance bill on top of his deductible that he had to pay, which is already probably $5,000 on top of that, just because his doctor owned that surgical facility and they don't join any networks. So the point about all of this is to make sure that you're staying inside the network. Anytime you're going somewhere that you pick where you're going, you always want to make sure that you're controlling that and staying inside the network. Now, here's the question to ask. Question is not if you're going to see a doctor or you're getting surgery, is do you take ABC insurance company, Blue Cross, United, Aetna, whomever it is, right? Everybody takes everything. The question is are you inside ABC insurance company's network? And they will have to answer that. And the best place to find it is to go online and look it up. Is doctors are in and out of these networks all the time. And we always want to make sure that that you are staying inside the network, and we always want to make sure that you're good to go. So always ask the correct questions. Always make sure that the doctors in the surgical facilities are inside the network. go online and double check to make sure your doctors are in the network. It is extremely important that you do that. Otherwise, you can see those big bills and those big issues that we have. Let's talk about PPO versus HMO. Some people might get confused, and I'll talk about both the group market. So if you're employer-based coverage and individual-based coverage as well. So if maybe you have enrollment through the ACA or something like that, or Obamacare, whatever you want to call it, is I'm going to also talk about that, which that open enrollment period is coming up right now too. So now is the time to make those changes and all that good stuff. But you could also have the option between a PPO network and an HMO network with an insurance company. And it looks different regardless of, or it looks different depending on which insurance companies that you may be partnered with. I can tell you a lot of the insurance companies that have an HMO network, it is a in-network only driven option. So usually HMO plans are much cheaper than PPO plans. And it's an in-network driven only option, meaning if you go outside the network, you literally have no coverage, right? On most PPO plans, you still have some out of network coverage. It's not much. I mean, you're talking 20s of thousands of dollars that you could potentially owe if you still continue to go outside the network, if you even have full protection. But on an HMO plan, you are completely exposed and completely on your own if you were to go into an HMO network, if you were to go outside of the network. So extremely network driven. It's usually a little smaller network than a traditional open, what we call an open access PPO network. So it's a little smaller network by design. And usually it's what we call a gatekeeper doctor. Now, not all networks are like this, right? Like Memorial Hermann, for example, has their own HMO plan where it's a little bit more open access within Memorial Hermann doctors, right? But like, let's take the number one HMO provider in the state of Texas, which is Blue Cross Blue Shield, right? And a lot of people have them through ACA or Obamacare, whatever it is they have a very large, but a very good driven HMO network, right? And so in that HMO network, it's what we call a gatekeeper doctor, meaning you pick a primary care physician. And in order to access any care within an HMO that HMO qualified plan, is that you have to go to that primary care doctor first in order to see a specialist or something like that. So if you have cancer, if you had even just foot surgery or something that you knew you needed, you still need to go to that primary care doctor first. That primary care doctor then channels you in to the different providers that you need, and it's all done appropriately and stays inside that network, right? You can see significant cost savings though in your premium of your plan by going to an HMO plan versus a PPO plan. So if your employer has an option for a PPO and HMO, you may be asking yourself, well, should I do this or not? And it really comes down to, and the question I answer for people all the time is, it all depends on how much you're utilizing care, how important your doctors are for you. If I'm talking to somebody and they're currently receiving cancer treatment at MD Anderson, they probably don't need to be looking at an HMO plan, right? But if you're somebody who doesn't go to the doctor very often and you don't care who your doctor is when you go see, you can save a lot of money by going on those HMO plans. Sometimes they're half the cost as to what the PPO plans are. So saving that money that's coming out of your check or that you're paying in premium is always going to be one of our most important things that we're analyzing when we're trying to decide which plan we're going to go with. Okay. I'm going to talk about telemed in a second. Does anybody have any questions on in versus out of network, PO versus HMO? I saw some chat stuff. I just want to make sure there's nothing I'm missing. Okay. Now let's talk about telemedicine. So we talked about staying inside the network and how crucial that is for you. Hopefully you guys are starting to see these telemedicine benefits come up on your plans. Most insurance companies are offering them with their medical plans. And we saw at post-COVID, we saw a massive spike in people utilizing telemedicine benefits after COVID. And so what it is, and there's multiple ways that you can have access to this telemedicine benefit. But if you're with one of the major insurance companies, you probably have this available to you. But what it is I like to say it's like Uber for doctors, right? Is that you usually have an app on your phone. Teladoc is a common one. HealthiestYou, which is actually owned by Teladoc, that are all together, is another common one. MD Live is another one like Blue Cross Blue Shield uses. They're all different versions of the same product. So essentially what they are is you download an app on your phone. If you get sick, if you get hurt, something happens, you need to talk to a doctor, you press a button on the phone, probably answer a couple health questions, and you can choose that doctor is then going to call you back, FaceTime, phone call, whatever it is. Doctor's then going to call you back. You're going to go over your symptoms over the phone with that doctor. And then they can even call in prescription meds. You know, falls supposedly coming down here in Houston at some point in time this year. you know, we're going to have the changing of the seasons, ragweed, whatever, all that kind of stuff. Maybe you're going through a sinus infection that happens to you every single year. And then rather than taking time off work, whatever it is, you can do it with a box of Kleenex sitting in front of you on your couch. You can press this button, doctor calls you on the phone, and you go over everything over the phone with them. Super great, super efficient way to utilize your care. And more importantly, if you're on a group plan, is those premiums aren't going towards your claims, right? Your claims are the number one driver in your premiums when you're on an employer sponsored plan, is that this helps insulate you from that. Now, there's two different types of ways that you can receive that telemedicine benefit if you have it available to you. And one is, like I said, through your plan, right? It's just built into your plan to where it's like, let's say you have a copay whenever you go to the doctor. Every time you use the telemedicine, it costs you about $35 or something like that, whatever your copay is to utilize that telemedicine benefit, right? Your employer can also purchase a benefit like this that's standalone, meaning you're paying maybe $11 a month in premium or whatever it may be, and you're paying that every month. And then you get access to that app now 24/7, 365 days a week at zero cost. And you can utilize it as much as you want, right? We're seeing that model to become the more prevalent one. But nonetheless, it's still nice to have that telemedicine benefit, even if it's built onto your plan and you're paying it per usage. It's still nice to have that telemedicine benefit there and available for you guys. Okay. Any questions about anything I've covered so far? Hopefully not everybody's sleeping yet. It is insurance, so I am used to it, but I'll give it a second in case anybody has anything to type. Okay. Now let's talk about your deductibles and kind of how plans are designed as a whole, right? So a lot of people get confused on this. Hang on, I got somebody in the chat here. Yeah, so somebody brought up a good point about PPO versus HMO. Some doctors don't ever work with HMOs, so HMOs aren't going to be a good option for you, and they just work with PPO. You know, a lot of doctors are like that. So it is very crucial that you always sit down and analyze, you know, like how it's going to work for you. I'm not saying everybody needs to be on the HMO versus the PPO, but it is always good to sit down, look at that, because I've also talked to people who are paying a lot of money for a PPO, come to find out their doctor is inside that HMO network and they could save a ton of money and just still continue to use their same doctor. So it's always good to look at it. It's always good to review it every year. A lot of this stuff you're going to want to review every year because doctors jump in and out of networks, prescription drugs fall into different tiers. It all happens on a cyclical basis. So make sure you're always reviewing your stuff. You're always double checking everything because it could save you a lot of money. So thank you for the question on that. Okay, so let's talk about your plan designs. And so when we're talking about plan designs, we're talking about your deductibles first. So let's start with what is a deductible, right? It's a fancy insurance word. Everybody likes to throw it around, but just to get down to basics, and a lot of people may already know what it is, but there could be people on that aren't even sure what a deductible is. And a deductible is just that fancy insurance word for how much you have to spend out of your pocket, right? Insurance deductibles can be $0, they can be up to $7,000. And everywhere in between, right? And then there's also differences between you have deductibles and you have your deductible, and then you also have what's called your out-of-pocket maximum. Everybody focuses on deductibles. A lot of people like deductibles and they focus on that. In my opinion, the most important number you will read if you get like a benefit booklet or whatever it is your out-of-pocket maximum. That is your hard cost that you know if you stay inside that network that you're never going to spend more than whatever your out-of-pocket maximum is per calendar year. Okay. And notice I said per calendar year. Now all plans are like this, but a lot of plans are like this. Let's say you're one of the people that I talked about in the beginning, that your plan comes up for open enrollment maybe in July or something like that. Or maybe you so if you come up for open enrollment in July, then keep in mind that a lot of policies are operating on a calendar year basis, even though your plan may renew on a policy year basis or like in the middle of the year, right? So here's the strategy on that, and think about that. It doesn't really matter, especially if you've been enrolled in the plan for more than a year. It's all the same for you no matter what. Every January 1st, you're going back and you're starting at zero. So here's the strategy on that, and a way to think about that is anything that you can control, like some people have elective surgeries or things like that. Maybe they have a tennis elbow that they've been meaning to get taken care of. Some people will wait until maybe the holidays or something like that in order to get all this stuff done and knocked out before the end of the year. That's a bad idea. And the reason why that's a bad idea is if you have not hit your deductible or hit your maximum out of pocket, then there's a chance that you could go in, have that surgery, wake up in the hospital, or go in the hospital on December 31st. You wake up on January 1st and you've met that deductible in 2022, and then you would have a whole new deductible that you got to meet in 2023. Right now, the good news is early on, if you go in early, let's say you don't get anything done this year, and then you schedule something for January, February, March of next year, and you hit that deductible and you hit that maximum out of pocket early in the year, then the rest of the year you have the ability to utilize your plan. Usually everything's covered at 100%. I'm not looking at any specific plan designs here, but usually after you hit your out-of-pocket maximum, the insurance company pays for the rest after that. So the strategy is, if you can control it, I know it's not always that way, but get your care done early in the year. Then that way you have the whole year at 100% coverage to get whatever may come up, whatever complications there may be, whatever you need done by the end of the year before the clock sets back to zero. Okay, and the deductibles go back to zero and the maximum out of pockets go back to zero. Okay, does anybody have any questions on that? Let's talk about individual versus family deductibles, because I believe this is important. Is that if you have an individual, if you're just covering yourself on the policy, usually you're just going to be subject to what's called the individual deductible. 0 to 7,000, whatever it may be, that's all you're on the hook for, right? Depending on how that plan is designed, which I'll talk about more, what co-insurance is in a second. But all you have that you're required, if you have employee only coverage or you're just covering yourself, is that individual deductible. Now let's talk about if you have family deductibles, right? If you're covering any other person on your plan, that's where your family deductible kicks in. Different plans are designed different ways, but you could have what's considered an embedded or an aggregate deductible. Okay. And so here's the way that works. An embedded deductible, which I have misspelled here, but which is most plan designs are considered embedded deductibles, not all, right? And it's important that you reference your specific benefit details to determine whether it is one or the other, but it matters a lot. So we try to normally push people on embedded deductibles. And what it is let's say you have family coverage, okay? Then you as an individual hit your deductible. And then nobody else in your family gets sick, which is the most likely situation. Only one person hits their deductible per year. And I don't care how many people you have on your policy, right? And in an embedded deductible, you're going to hit that and then you're done. It works like an individual deductible for you and from your standpoint. Now, if your spouse, on the other hand, needs to go in and get some work done, they're still working towards their individual deductible, right? And then as a family, let's say you have a family of 4, everybody could be working towards that family deductible. Once that is hit, then everybody's done after that, right? And that's what an embedded deductible is. It gives you the ability to utilize it as an individual plan or as a family plan, okay? Whereas an aggregate deductible is a little bit different. And it is and usually they're cheaper plans if you have an aggregate deductible. But the way that works is if you're an individual on the plan, it's an individual deductible, right? But if you're a family on the plan, then you have a family, whether one person hits that family deductible or not, right? So you don't get that hybrid kind of role like you do in an embedded deductible. So on an aggregate deductible, it is if one person needs to meet the family deductible, and the family deductible could be $14,000 or $8,000 or $10,000, whatever it may be, you could be on the hook for all of that all by yourself. So it's important to ask those kind of questions when you're reviewing which plans you're going to enroll in, is that maybe an embedded deductible is just a few dollars more and it saves you way less hassle and gives you way more flexibility on the back end. Those are the things to kind of look at. Okay. And then once somebody hits their deductible, that's where co-insurance kicks in. And a lot of times you see it'll say coins or something like that. Very few people really truly understand co-insurance when they're looking at this stuff, but let me explain how it works. And it's kind of hard because it depends on your plan design, and I'll go through what are some common plan designs. But once you pay your deductible on this plan, and the insurance kicks on any plan, then the insurance kicks in, and then they will pay a percentage of every bill after that up until you hit that out-of-pocket maximum that we discussed. Okay, so a common plan may be like you have a $3,000 deductible with 80% coinsurance, okay, with a $5,000 max out of pocket, just to leave an example. So what that means is you're subject to everything up until that $3,000 deductible is met, right? Then the insurance kicks in and they're going to pay 80% of every bill after that. You're going to pay 20%, and you're going to continue to do that cost sharing for an additional $2,000, right? You're doing that 80-20 split for an additional $2,000. Once you paid an additional $2,000, now you paid $5,000 for the year and you hit your out-of-pocket maximum, and everything's covered at 100% after that. Okay, I'm going to walk through that one more time because I think that's super important, and it's the ABCs of how a medical plan works, right? Is that you're going to pay your deductible. Then the insurance company is going to kick in. They're going to pay their co-insurance, whatever percentage that may be. And I used in my example 80%, but there are some plans that have a deductible and then they have 100% co-insurance, right? So the deductible and the maximum out of pocket match each other. So if you have a $3,000 deductible and it's 100% co-insurance after that, then your maximum out of pocket is usually $3,000, not always. And I'll talk about that more in a little bit. Okay. So pay your deductible, co-insurance, then your out-of-pocket maximum. And your out-of-pocket maximum, just to remind everybody, is that firm number, right? Whatever your out-of-pocket maximum is, that is the worst case scenario, right? Most people don't hit their deductibles. They don't hit their out-of-pocket maximums in a calendar year, right? In a group of 10 employees, right, usually maybe one would hit their deductible in a calendar year. So let's talk about what is subject to the deductible, right? The things that are subject to the deductible are only major things, right? We're not talking about your primary care doctor visits or your specialty doctor visits or anything like that. What we're talking about is CAT scans, MRIs, outpatient surgery. Maybe you get hospitalized, right? Big stuff that happens to you throughout the year. Knock on wood, most of us don't utilize our deductible in a year. But if you did those major things, if you have any of those big things happen, subject to the deductible, co-insurance, out-of-pocket maximum. And I know I keep repeating it, but I think it's extremely important that everybody understands that. Okay? Any questions on that? Everybody pretty good? Let me give it a second, see if there's anything in the chat. Okay. So now let's talk about, so we talked about how you're going to utilize your plans. Let's talk about urgent cares versus ERs and emergency rooms. Okay, this is another way that a lot of people have kind of been conditioned to go to these emergency rooms and things like that. That if we can break that condition and become much better consumers of our healthcare, which you're going to hear me talk about a bunch today, then I think it can help. It can help save you guys some money, and if you're on a group policy, it'll help save that as well. So let's talk about the difference between emergency rooms and urgent cares, right? Emergency rooms, which everybody sees, are attached to all the hospitals. Sometimes you've even seen some of these new private emergency rooms. Maybe you got one outside of your neighborhood or something like that. You really only want to go to an emergency room if it is truly, truly a life or death situation, right? Like you really don't know what's going on with you and you think you might be dying. An urgent care facility can be utilized throughout the year for most major things that you have happen to you. So here's what I'm talking about. If you break bones, if you have surgery, or I'm sorry, if you need stitches, maybe you have just something going on with you. Like I've been in for my neck before, but maybe you just don't know what's wrong with you and you're scared, whatever it is, you can go to that urgent care facility and it's going to be much cheaper. On a lot of plans, like a traditional copay style plan, urgent care visits $85, $100, maybe even $50, somewhere around there. And it covers everything that happens in that entire visit. That's it. If you go to an emergency room, even though you may have a copay associated with that emergency room, that copay usually only covers the emergency room doctor, right? It doesn't cover what is called the emergency room facility fee, which we talked about in the beginning when talking about outpatient surgery. So whenever that's the case and you go to that ER, I don't care how minor of a thing that you have done, they have been giving stitches since caveman times. And for some reason, they're more expensive now than they've ever been before. The technology is not any different. It's still a thread and needle, but for some reason, it's a lot more expensive. So When you go to the ER, I don't care how minor of an issue you have done, you're looking at easily spending at minimum a close to $1,000, if not $1,000 or more. Okay. So to go to an urgent care facility instead, you can get in, you're usually going to get in a lot quicker. I don't know if anybody's spent any time in an ER waiting room lately. They're not a lot of fun. I know I have. And so going to an urgent care, you're going to get in and out a lot quicker. They can handle most major things that you get done and taken care of in that office. And like I said, really only the ER needs to be life or death, right? The ER is always going to be considered in network as long as it's a true emergency, right? If you're going, and I've had this happen before, is I know a guy had a claim denied because he went to the ER, thought he was having a heart attack, and turns out it was acid indigestion or something like that. Well, originally the insurance company denied the claim, saying it wasn't a true emergency. It's not even that they denied it, they just handled it not in the appropriate way or classified it in the appropriate way. And so he came to us and said, look, it was an emergency to me. They were saying it wasn't an emergency. He goes, it was. I thought I was dying. I thought I was having a heart attack. And they went back, reviewed the claim, and that's exactly what an ER is there for. They're not trying to make you determine whether you're actually going to die or not, right? It just really has to come down to, is it a true emergency or not? Now, if you're going to the ER, you just got the sniffles, they're not going to code that the way you want that to work out for you, right? Because it's going to be a super expensive sniffle visit if that's what you have to do. So it's extremely important you can go to these ERs instead of these, or go to these urgent cares instead of these ERs. But there's a gotcha to that. The thing you always got to want to watch out for is, one, you need to make sure it's an urgent care, right? Is a lot of these private emergency rooms that you see outside these neighborhoods that kind of can blend and look like that. If you see the word emergency anywhere on the outside of that building, that is not an urgent care center. That is in a private emergency room, and they will take care of you. I don't want to sit here and act like private emergency rooms won't take care of you. They will take care of you. They will do a great job of doing it, but you're going to get a bill afterwards, and it's going to be really, really expensive. And you're going to be like, golly, why didn't I listen to that smart insurance guy whenever we were doing that presentation, right? Is that you really want to make sure that you stay and you go to those urgent care facilities instead of those private emergency rooms in order to receive the maximum benefit that you can. Now, another thing you need to watch out for when you're talking about urgent cares is you always want to make sure that they're in network urgent cares. Most of them are, but you always want to make sure that they're in network urgent cares. Once again, back to our network discussion, you're controlling how you utilize that, or you're controlling your access. So you always want to make sure it's in network, right? And then the last thing is not all urgent cares are built equally, right? Some of them turn into private emergency rooms later in the evening, right? Or some of them are 24-hour urgent care. Some of them have x-ray machines in. So here's what I suggest everybody does, is that when you go through your open enrollment period or any time, right, whatever your network is, and I don't know how much people actually listen to me on this or not, but I think it's the best way to do this, is to go online, find an urgent care, maybe one near your house. If you have an office, then find one near your office and drop a pin on it. Maybe have one that you know is 24 hours so that you can access it, worst case scenario. Because what happens is most of us get sick, get hurt. We're not thinking clearly anymore, right? You're in pain, you're uncomfortable, and you just want to feel better. And so you go wherever you can go to make yourself feel better, regardless of the cost. And then you start feeling better, and that's about the time the bills start coming in, and you have a little bit more mental clarity, and you are like, what am I paying for here, right? And so that's why I suggest people go online, drop a pin on your urgent care facility, maybe one near the house, one near the office, that if you get sick, if you get hurt, boom, this is where I'm taking my family, this is where I'm taking myself, and it's going to control that cost for you. Okay, I have a question here. Give me 1 second to read this. Yep. So we had a question about calling 911 and they take you to the ER. So just think about this, and this is exactly right. You don't need to be making life and death decisions, right, in real time. Like you need to get taken care of, and you need to make sure you're getting yourself taken care of, whatever that may be, right? But it's important that you understand that it has to be a true emergency. But nonetheless, if you call 911 and you take that ambulance ride, it's going to be an expensive day. A lot of ambulance rides aren't inside all the networks. And so I just want to make sure that everybody understands that the second you do call 911 and take that ambulance ride. It's going to be covered. You'll still have some protection, but just keep in mind your deductible or your max out of pocket, boom, is going to be met by that. But you bring up another point that I want to make sure we talk about, and that's balance billing. I meant to talk about this when we talked about the networks, but it still applies here because these are a certain type of doctors that everybody's probably encountered. So I talked about doctors joining the networks and things like that and making sure they stay inside the networks. ER doctors specifically never join any networks. So there are certain types of doctors that are very hard to get to join networks. And there's an acronym in there that you will be able to figure out, but it's radiologist, anesthesiologist, pathologist, and emergency room doctors, right? Usually you don't pick those doctors. Those doctors are given to you, or you show up somewhere and you're just assigned them, right? And so those doctors generally don't join networks. And so the problem that the healthcare system was having is that you have these group of doctors that you don't ever get to pick. They never join in any of the networks, and then you get balance billed for it. The insurance companies, and Lori, more to your question about the ER and the ambulance visits, is if it is a true emergency, it will always be considered in network. And regardless of whether they are out of the network or not, it doesn't matter, is that it's still considered in network charges, and they're still charging you the in-network charges as long as it is a true blue emergency. If it's not, then it's not going to be counted that way. Like if you go and you call 911 and it is just the sniffles, and that is going to be a very, very expensive ambulance ride. So it's really crucial, and I'm not saying anybody's doing this, but it is crucial that you make sure that it is a true emergency whenever you're utilizing that kind of stuff. Okay. Any other questions on that? Thank you for the interaction, Lori. I really appreciate it. Any questions on ER versus urgent cares? All right, let's keep on keeping on. Now let's talk about your pharmacy. And I think that this, outside of urgent care and ER, this can be an extremely important part, and it's changing a lot, right? Is that prescription drugs, I mean, I'm sure people have heard horror stories about some prescription drugs that can cost $3,000, $30,000. I've seen prescription drugs that cost, hundreds of thousands of dollars per fill. I think it's important that you identify the different types of drugs that you may be taking. And there are some cheaper alternatives that are available to you. I'm not saying everybody needs to go to like just generics or something like that, because certain brand name drugs work for just you. But it's always good to know and be an active consumer and have that dialogue with your doctor, right? And so here's what I mean by that. A lot of pharmaceutical plans, and especially like Blue Cross Blue Shield, who's one of the largest health insurance providers, they go through there and they require you to take generics first and prove that those generics don't work before they allow for a brand name cost. Because remember, the insurance company's job is to control costs as best they can so that they're paying out less in claims and just collecting in premium, right? And so in order to do that, what they've done is they say, well, we're going to require you to be on a generic drug first and foremost. And only when you prove to us that that generic is no longer viable for you, will we allow you to go onto a brand name. That is called step therapy, right? And so that is what those insurance companies are doing. However, if you are sitting down and talking to your doctor, and we're just talking about something minor, maybe you need blood pressure medicine for the first time, maybe it's cholesterol medicine, a lot of stuff, maybe it's just oral diabetes medicine or something like that. A lot of those medicines are generic available. So if that doctor is trying to prescribe you a brand name drug, it's always good. If that doctor has their pad out and they're about to write you a prescription or whatever it is, or call in that prescription, it's always good to mention to that doctor, and you can do this. You can be an active consumer of your healthcare. Create a dialogue with your doctor. Don't just close your eyes and sit there and just whatever they say, you just do, right? Is that have a dialogue with them. Make sure your doctor understands the financial impact that their decisions are having on you as a person, right? And as a patient. So you want to have that dialogue with them. And so if that doctor does prescribe you the medicine, just be like, hey doc, just want to make sure generic, you got me down for a generic. Usually they'll always say yes. Usually you're good to go on that. But if sometimes they may not, and it just helps point them in the right direction, right? So that's another way to save a bunch of money on your prescription drugs. So it's going to fall into one of three categories. You have your generic drugs, which have been out on the market for usually a long time. Everybody makes them. Brand name drugs, which are the ones you see the commercials for, right? If you see them on TV, that means they're expensive, right? So you want to always make sure that you're having those conversations with your doctor, and then your specialty drugs are going to be your really high end, very specialized, very specific conditions that they're utilizing. And those are the people that are on those, maybe they're in cancer treatment or something like that. Those are the big ones, right? So the way your prescription drugs may be handled on your plan, it can be a variety of different ways. Is maybe you have what are called traditional copays whenever you pay those prescription drugs. So some generic drugs can even be free, right? Some insurance companies are allowing, like if you're on blood pressure medicine, diabetes medicine, they call those maintenance drugs, right? And so, or preventative drugs. And so the idea is that by taking those meds, it allows you to reduce your overall cost to where your impact to the plan is going to be cheaper than if you didn't take those meds. So they give them to you for free, right? Not all insurance companies are there, but I mean, I've bought generic drugs before on my plan, and I don't have a traditional copay style plan, which we're going to talk about in a second. But I've bought generic drugs, 60-day fill, whatever it is, 90-day fill, and it was like $20 or $16 or whatever it is, right? So you're talking about really, really cheap pricing. That's the importance of making sure that you indicate that you want generic drugs rather than brand name drugs, if that works for you. Okay. Any questions on the prescription drugs? Keep myself from losing my voice here. Let's keep going. So now let's talk about high deductible health plans versus copay plans, right? And some of you may have seen the difference between the two, or maybe you've heard of the term HSA or FSA or whatever it is. Let's talk about how these two different plan designs work, okay? Most people in a more traditional style of a plan is called a copay, what we call a copay style plan. So it could be a PPO, could be an HMO network, right? But we're just talking about the plan design. So you have your network as one part of it, and then you have your plan design as the other part. On a traditional copay plan, what that means is that you still have your deductible, you still have your co-insurance, you still have your max out of pocket like we discussed earlier. You may also have copays when you go to the doctor or get prescription drugs like we just got done talking about. Normal copays can be like $35 for your primary care, maybe it's $65 or $70 for your specialist. And when you pay that amount, that covers the entire doctor visit, right? Now, if that doctor codes something differently outside of that doctor visit, then you may have to pay that subject to the deductible or something. But nonetheless, is that if you pay your copays, you're going to pay your copays, and that's all you need to worry about. They'll take care of it after that, right? There are some plans that are what we call high deductible health plans or HSA qualified plans, that the way they're designed is that they don't have copays when you go to the doctor. They don't have prescription drug copays. And that doesn't mean that you're paying for those doctor visits or those prescription drugs for free, right? It doesn't mean you're not paying for those. It means that you're paying actually the full price on those. You still get discounts when you utilize your insurance plan, but you're paying for that full price. So I don't mind telling you guys, myself, if I get sick and go to the doctor, easily we're just south of $100, right? Is it fun to pay $100 every time I need to go to the doctor? No, it's not fun. But the plan I chose, those high deductible health plans or the HSA qualified plans, are cheaper than a traditional copay. Now there's parameters on that as far as what the deductible size is, but plainly speaking, if you have two equal deductibles, two equal maximum amount of pockets, and this one plan has copays and this plan doesn't, the plan that doesn't have copays is going to be cheaper for you, okay? And the people that come out ahead on these high deductible health plans, which I'm going to talk more about, they're the ones that maybe they don't go to the doctor very often and they don't utilize their care very much, or maybe based on the plan design, if your out-of-pocket maximum is cheaper on the high deductible health plan, then you're coming out ahead, even if worst case scenario, you have surgery or something like that. If that max amount of pocket is lower on the high deductible health plan, you're usually going to prefer that high deductible health plan, because remember, everything's still subject to the deductible the same on both plans. It doesn't matter. We're only talking about, getting sick and going to the doctor. I love a $35 copay or a $30 copay as much as the next guy, but I don't need insurance to cover my small $100 doctor visit, right? I need insurance for a $30,000, $50,000, $70,000, $1 million bill like I talked about in the beginning, right? So the way I utilize my plan is I go with a high deductible health plan, HSA qualified, low premium coming out of my check, And that works for me and my family. Now, the people that like copays, maybe they have some chronic conditions, maybe they're on some higher end prescription drugs, or going to the doctor half a dozen times a year or something like that. And for them, from a cash flow standpoint, that high deductible health plan doesn't work, because they don't want every time they fill a prescription for it to be $200 or $300, right? Now, those amounts, when you pay those on a high deductible health plan, are always going towards your out-of-pocket maximum, right? So everything you do on all plans is always going towards your out-of-pocket maximum. The only luxury you give up is that copay when you go to the doctor, and that prescription copay. Some people that works, some people that doesn't, okay? So copays, that's what we call first dollar coverage whenever you see that there, right? If you're on a high deductible health plan that is HSA qualified, this is the way it works. So the federal government says, once again, in their infinite wisdom, is that if you're brave enough to be on a plan that has a high deductible and that doesn't have copays when you go to the doctor or get your prescription drugs first dollar, then what we will allow you to do is that you're going to pay your premium every paycheck, right, or every month, whatever it is, but then we will allow you to put an additional amount of money into a savings account on a tax-free basis, right? And you can utilize that money on any medical, dental, or vision expenses that you may have throughout the year. A lot of people compare these to like FSAs or flexible spending accounts. And if you've ever listened to the radio around Christmas time, you've probably heard it's like, hey, don't let your FSA dollars go to waste. Come in and get your glasses or get your eyes checked or whatever it is. And that is because on a traditional FSA, it is use it or lose it, meaning the money you put into that flexible spending account that you can utilize for medical, dental, or vision or daycare or something like that, those tax-free dollars, is that if by the end of the year you don't use that money in that account, it goes away. It's all house money after that. On an HSA or health spending account, right? Or health savings account, I'm sorry, is what we will allow you to do is you put that money in that savings account. It's in a bank account in your name. If you don't utilize that money throughout the year, maybe you stay healthy, what a novel idea, and you put $1,000, let's say, into your HSA account, it rolls over every year and you continue to fund it. The idea is that you fund it while you're healthy, right? While you're having some good years, keep putting money in that HSA account. It gets bigger and bigger. Then maybe you have that deductible sitting in that account, or 2 years worth of deductible sitting in that account, and you're utilizing tax-free dollars for your medical, dental, or vision expenses, right? And so that's what's really nice. And there is a ton of flexibility within HSA plans, okay? And so what I'm talking about is that I've been contributing into an HSA for going on 15 years now. I don't do a ton every year, but if you put in your money, and if you just think about it, let's say I just did $1,000 a year, right? Slow dripped it in there. Now, after 15 years, I've been healthy, knock on wood, right? I've used very little of my HSA money. Even if I use some of it, let's say 3,000, I had one bad year. Even if I use some of it, you can see I still have quite the good chunk of cash sitting in that bank account, right? And then what's even nicer is I have 30 more years of work ahead of me probably, or 20 more years of work ahead of me, hopefully. And so that's a lot more years that I can continue to fund that account. It gets bigger and bigger and bigger, and it almost works like a supplemental retirement plan or something like that. I've even taken it, because it is a traditional savings account, and hopefully most of you realize that traditional savings accounts it might be about to change, given the Fed, but they don't pay much on your money that you have sitting in there, right? And so what you can also do that I've begun to do is I leave about 2 years worth of cash sitting into my HSA account. Any surplus I put in there over and beyond that, I then channel into a mutual fund within the bank that manages my HSA. They have their own suite of mutual funds that I can then channel that money into. And then my money is working for me just like a normal retirement plan. And it's tax-free dollars that are sitting over there in the market. Huge advantage, right? And I can continue to pay for my medical expenses, let's say with just my regular credit card or debit card or whatever it is. And at any point in time, let's say I'm on a high blood pressure medicine, okay? And if I'm on a high blood pressure medicine and I've been sitting here and I've been taking it like clockwork, high blood pressure medicine, month in, month out for, let's say, the last 10 years, right? And let's say it's $20 a fill. So for the last 10 years, every month, I've been spending $20 every month for my high blood pressure medicine. Let's say I fall on hard times and I need to maybe I wish I had taken some of that money and I used it in my HSA instead of just paying for it on my credit card, is I can reimburse myself at any point in time, retroactive back to when I had my HSA established. So for all 10 years, I can reimburse myself any amount of money that is owed to me at any point in time. It gives you a ton of flexibility. You always want to make sure you're talking to the right people, because if you do have an expense and maybe you utilize that debit card on a non-qualified expense, medical, dental, or vision, the ramifications of that can be big. So we're talking about if you're under 65 and you use it for a non-qualified expense, let's say you have money in that HSA and you buy groceries with it, or you buy a plane ticket or something like that. Nothing's going to happen to you, but if the IRS audits you and you don't have proof that that's a qualified expense, then you're going to pay a 20% tax on it, or you're going to pay taxes on the expense, and you're going to pay a 20% penalty as well, right? So you always want to keep it qualified. Now, once you hit 65 and you hit that magical Medicare age, the good thing for you is you can spend that money on whatever you want. You could buy a boat with it. You could buy a house with it. It doesn't matter. You're just going to pay taxes on it if it's a non-qualified expense. I don't know about most of you, but the older you get, generally, the more your healthcare spend is. So a lot of people tend to leave it alone. Maybe they use it for long-term care later on down the road or something like that. But the HSA products give you a lot of flexibility and a lot of advantages. The only people that really normally don't come out ahead, like I said in the beginning, on those HSA products are people that have that kind of middle range of healthcare spend. Maybe you're never going to hit your deductible, but you go to the doctor a bunch and you take some prescription drugs. And just from a cash flow perspective, every month, you don't want to be sitting and shelling out a bunch of money, or just a mental peace of mind of knowing exactly how much it is. That's why people like those traditional copay plans. I do have a question here. I'm going to read this real quick. If anybody, I'm going to pause for a quick second if anybody has any questions while I read this. Okay, good point. Angie brought up a really, really good point. And here's her question. If the insurance company wants you to use a specific pharmacy in order to save money, is it worth making the switch? I keep getting letters asking me to review prescription plans. Very, very good point. So you can have different prescription plans for your group benefits, but a lot of carriers are getting to where they have what they call preferred pharmacy vendors, right? And I'll tell you the big one is CVS, right? Aetna forces you to use CVS. Aetna is owned by CVS, for those of you that may not remember. So that's why you see a lot of that there. With Blue Cross Blue Shield, they push you into Walgreens, and CVS isn't even inside the network at all. It is something that's worth reviewing, is that when you're talking about your pharmacies and all that stuff, it is always worth reviewing and call. And especially when it comes to HSAs, if you have an HSA option and it's something you want to consider, I always tell everyone, especially if they're on prescription drugs, call your pharmacist and have a conversation with them and ask what the cost of those drugs would be if you didn't have those copays. But it is, Angie, to answer your question more to the point, it all is specific on your particular plan designs and things like that, but it could be worth doing if you can save some money. Another thing that a lot of people see, back to the prescription drugs, when we're having these kind of conversations, is you'll see maybe if you use, if you don't have a copay whenever you utilize your plan and you have a prescription drug of some type, then your pharmacist will say, well, if you use your health insurance plan, it's going to be X number of dollars, but if you use this GoodRx card or this discount program, it's going to be cheaper. And here's what I tell everybody on that. Use the discount program. I have no problem with you using the discount program over your insurance, especially if you're never going to hit your deductible. That makes a lot of sense. Do what saves you the most money at that point in time. Just keep this one thing in mind if you do decide to do that. If you decide to use a discount program rather than using, your actual insurance plan, then know that you're not going to be getting credit towards your deductible, right? Or your maximum out of pocket, is that you're essentially paying for this outside of everything. Now, if you're never going to hit that deductible, it doesn't matter, right? So take advantage of that discount program while you can. Okay, I got another question here. Okay, good question, Pat. Pat asked, can retired employees on Medicare somehow open an HSA account? And the answer is no, not right now. So once you agree to take Part A on Medicare, is that then disqualifies you from the tax advantages of an HSA. So very, very good question, Pat, is that you cannot take advantage of the HSA if you are retired and you're currently on Medicare. Now, if you're still working, even if you qualify for Medicare, like my dad, for example, is 67 years old, 68 years old, and he is still working and he is on an HSA qualified plan. He denied Part A because, or he used to deny Part A because he wanted to continue to take advantage of that HSA program. Pat, I can also tell you I'm involved pretty heavily legislatively, and we saw the expansion of HSAs during COVID. We saw a massive expansion of HSAs, and from a legislative perspective, you're seeing the Republican Party, generally speaking, playing ball finally with the Democratic Party as far as the ACA goes. Not to get political or anything like that. I'm not going down that road, but to your point, Pat, is I think in my infinite wisdom that I do believe an expansion of HSAs into the Medicare market is coming. I do think the Medicare market has become too rich and we're having so many people jump into it. I think the system is going to start getting stressed a little bit. And I think you can see HSAs and expansion as a kind of a release valve for you in that market. All right, I got another question here. Yeah, Miriam, good question. So you have to save receipts. That's exactly right. Now, if you have, most of these are operating like credit card, debit cards, whatever. They normally operate like debit cards, but you have a statement on those, right? So you always have your historical data, usually online. So I don't really save any of my receipts personally. I just have that transaction history, just like any normal bank account does. Okay. Any other questions on the HSAs? I think they're a really, really great benefit and a lot of people can take advantage of them if you have it available to you, but not all health plans are HSA qualified. So you always want to start with that question first. Okay. Any other questions? Thank you guys for participating. It's great. All right. Keep going. Now let's talk about preventative care. This is one of the last things I'm going to talk about here because it's the free stuff, right? Is everybody likes free stuff. Is that hopefully everybody realizes on all plans, both high deductible health plans or HSA driven plans or co-pay traditional plans, is that everybody has preventative care. This is part of the ACA. This is part of that entire Obamacare package, is that it determine what all policies have to have available to their policy holders. So one of them, all of this is preventative care. So if you want a comprehensive list of what all falls into this, because men have different preventative care needs than women do. So there's a variety of different ways you can do this. But by and large, all plans, physicals, everybody gets one for per year for free. If you're on an HSA qualified plan, that means no co-pays, no nothing, no anything. You should walk in and walk out of there and never have to pay a penny, right? Ladies, if you're on a plan, well woman exams, those are free as well. And we're talking about if you're 35 and over, I believe it's 35. They change the numbers on all this stuff all the time, the ages on all this. 35 and over, you can get a mammogram every year as well for free, right? Colonoscopies, those are only for 55 and up, or they may have dropped it down to 50 last year. I can't quite remember, but it's 50 and 55. Double check it on your policy. But the way it works is that you can get a free colonoscopy once every 10 years, right? And so a lot of people ask this question. They say, well, I suffer from XYZ condition. My doctor says I need to go every 2 years or 4 years. Will they make it free then? The answer is no. Is that if you're on any schedule other than what the government approved list is, then you're going to pay for those and they're going to be subject to the deductible. More so to the point, if you're sitting in that physical and you call your doctor, you say you want to go do a physical, you sit in that doctor's office and that doctor says, well, Mr. Raymond, it's good to see you. How have you been? And I go, well, I've been suffering from this elbow issue or shoulder issue or knee issue or whatever it is that I've been suffering from. That doctor's probably not going to continue to code that as a preventative visit, meaning a free visit. And what they're going to do is that is now diagnostic. They're now trying to figure out what is wrong with you. And so you're going to pay for that visit. So if you want it to be truly a physical, it needs to stay kind of condition agnostic, I would say, and it needs to be a true physical. If at any point in that time that doctor codes that differently, you're going to pay for that doctor visit. But it's great to know that that's where you begin, is that doctor visit is going to be free no matter what. Now, on the colonoscopy, let's talk about this because this can affect two different people, okay? If you go and get a colonoscopy and it's free and that doctor doesn't find any polyps, you're good to go. It's all going to be free, right? But a lot of times you're put under anesthesia when you do a colonoscopy and you don't know whether they're going to find polyps or not. So it really is kind of a gamble. So it's not really a gamble because you don't want to gamble your life on not going to get your colonoscopy and potentially having colon cancer or something like that. But when you go down and you go under, if that doctor finds any polyps, they usually snip them out right then and there. That is now a surgical expense that you didn't know you were going to have before you fell asleep. Story I tell happened to both my parents. Dad goes in for a colonoscopy. He has polyps. Those get snipped out. He had to pay. Mom goes in for a colonoscopy, no polyps. She never had to pay. There's not really anything you can do about it, but it's good to know going in exactly how they're going to treat those types of things. Okay. Any questions on that? It's extreme.
It almost makes you want to not do it. I mean, if you're still running the risk of getting a bill, that's like the quickest way to scare somebody from not getting it done.
I mean, that's exactly it. Is you could have that subject to the deductible, and I mean, you're talking potentially $800,000, maybe even $2,000 bill, depending on how many polyps get snipped out. And Nia, you're hitting on a greater subject here. That is, you know, when these healthcare companies are designing these health plans, and when we're working with client employers on how to set those types of things up, is that's one of the things that we have to figure out is you don't want to plan. And that's what some people say is the downside to like a high deductible or an HSA plan, right? Is that fear, like you said, is that if you don't know how much it's going to be every single time you utilize your doctor, then that fear can keep you from getting the care that you need, and then it can exacerbate what would have been a small problem and a small claim problem if you had addressed it early, right? Just like your car works the exact same way, right? Everybody knows if you change those brake pads on time, then it's not a real expensive thing. But if you wait too long and you got new rotors you need to replace, it's expensive. And this works the exact same way. We also get some fallacies when it comes to health insurance, and I've given these open enrollment meetings for my clients all the time, and I've had people interact with health insurance different than they do every other type of insurance they have. And what I mean by that is there sometimes can tend to be some entitlement and some misunderstanding as far as the way a health insurance plan works. I've had people that are on $7,000 deductibles, or they have a $10,000 family deductible or something like that, and I've seen grown men cry in meetings. I've seen people wad up their paper and throw it in the trash. I've seen people tell me this also when we're doing these meetings, is they say, well, shoot, these deductibles are so high, and they have gotten high, right? Is that I'm better off, you know, at the end of the year, making sure I, you know, hurt myself to make sure I get my money's worth out of my health insurance plan, which blows me away because most people that drive around the city of Houston have car, or you're supposed to have car insurance. And I don't see anybody jamming their car into a concrete median to make sure they get the most out of their car insurance, or setting their house on fire to make sure they get the most out of their homeowner's insurance, right? Is that we have this condition with healthcare, and copays have kind of helped create this, that you have this expectation of that first dollar coverage, and that things, you don't even know how much these doctor visits are because you've been so insulated from them by paying these copays or these prescription copays. And the transparency issue that we have at some of these hospitals, that you're seeing healthcare reform start to kind of get in line, is that I was talking to somebody the other day. They had a CAT scan that they needed to get done. And this is extremely important when you're talking about controlling cost, right? Is that if you go and you need to get that CAT scan or that MRI, and you go into the hospital CAT scan or MRI or imaging center, it's going to be a lot more than if you go to these standalone imaging centers, right? And a lot of doctors will just push you into that hospital system and push you into that imaging center, right? But if you go and just say, tell your doc, look, I'll take care of my own CAT scan, MRI, whatever, make sure it's inside the network. And you can even go online and shop those things, but you're starting to see much more transparency from these hospitals. They're supposed to be putting out an entire list. They make it very hard to find, in my opinion, of how much these things cost. But that open, transparent market is what has been missing from the overall consumerism that is allowing you to pick, you know, where you're going to access care and how you're accessing that care, and what the financial impact is of, you know, for you. You bring up a point of I don't even know how much it's going to cost. So then people are just so indecisive. about it. So that's kind of the idea behind it, but you're starting to see that there is that I don't know, but nonetheless, just having the full information and having that conversation with that doctor ahead of time can help, because nobody likes to pay, obviously, but understanding how your plan works and why you have to pay makes it a little bit easier sometimes. And the thing about health insurance, I like to make sure everybody keeps in mind and keeps perspective is that when I say $7,000, $10,000 deductibles, those are big numbers, right? Nobody's expecting you to have $7,000 and $10,000 in cash walking around in your pocket, and that if you get sick and go to the hospital, that you're just writing them a check, right? Is that what I like to bring up to everybody, and the beauty of having health insurance, and it seems silly that I have to present this, but it's the truth, is that $7,000 and $10,000 is a number that you can eventually pay off, right? Is that you can eventually, pay that off, pay that $7,000, pay that $10,000, go on a payment plan with that hospital, whatever it is, and pay that off, right? But what you can't do is that if you go without health insurance, and then these $1 million bills, these hospital bills that cost $100,000, if you draw the short straw and you have one of those big ones, is that you may financially never recover from that. That can prevent you from buying a house later on in the future and things like that. So it's important that it's a controlled amount of risk. It's a manageable amount of risk that everybody keeps kind of that perspective on. Okay. All right. Let me answer some questions here. I got a few of them. Yes, we do have some people. Everybody's talking about, like, when it comes to colonoscopies, things like that. I think it's important to know is everything I'm talking about when I talk about preventative care, everything, the way the entire function of a health insurance plan works is doctor codes, right? Is that how those doctors code those services when it gets sent off to the insurance company? That's what dictates everything. And so having that conversation with that doctor can control that output as well. So it's important to remember that. Okay. A couple more questions here. Yes, that's exactly correct. You can request that you don't get put under during a colonoscopy, and that's dealer's choice on that. I know some people that have. I know when the day comes that I have to do a colonoscopy, I'm going to be requesting that I get put under. But she's exactly right. You can save some money that way, have a conversation with the doctor, and decide whether those polyps need to be snipped. I would tell you, usually whenever you're going under a colonoscopy, that's why those doctors do it, is they need to be snipped. They need to be taken out. They're precancerous potentially. And so you need to make sure you get that taken care of. I love saving money. I don't like seeing people spend money unnecessarily, but I don't want anybody ever making, financial decisions, risking their health in order to make such financial decisions. Is that it's not worth it. Is that make sure you take care of yourself first, and then the financial decisions afterwards. Okay. All right. So we got a question here. So it looks like somebody had a copay on their current plan, jumped up pretty big to $15. Not sure what it was before, but I can tell you this, is that every year your company that you may work for, or whomever it may be, even the city in some cases, they analyze this stuff. Their HR departments sit down, they review the plans that are being offered. And so, yes, that's correct. You could refuse the services, but they review all that stuff, and then they make adjustments all the time, right? Is that just like inflation happens, there's deductibles that creep up over time, maximum out of pockets creep up over time. You're seeing copays are getting hit harder, whereas we used to have $0 or $5, $10 copays. You're seeing 15, 35 is really common now, 70, 80 for specialists, things like that. Urgent cares are like 100, 150. So you see stuff kind of keep up with the inflationary model. I would tell you that, in my opinion, the medical model overworks the inflationary model, so to speak. But I want to make sure just everybody's kind of keeping that in mind. Okay. But yeah, it is due to inflation, just to answer your question more directly. Great point.
I have a question in regards to the mammograms.
Mm-hmm.
So how is it that some insurance companies, they'll cover you to get mammograms done, but if there's something that's found, if there's something suspicious or whatever that they need to take a further look at, that they don't cover then the diagnostic or the additional tests that are needed to figure out what the problem is?
Yep. So let's and not to nitpick too much, but words matter a lot when it comes to insurance. So I'm going to nitpick what you said a little bit there. Okay. So there's two different things we're talking about here. You use the term not covered. Okay. And that may be the case. It may not be covered, but most of the time, the way most consumers use that term is incorrect in that to them, when something is subject to the deductible, meaning they have to pay the out-of-pocket cost or whatever, and it's subject to the deductible, to them, that means it's not covered. And to us, it means it's covered. It's just being handled as subject to the deductible rather than as the full preventative, right? So it's still a covered expense. You're going to have all the same protections that you have on your plan. I think that's important that we have that dialogue and talk about those definitions. But more to your point is that if that doctor does anything diagnostic and they code that, then now that is subject to the deductible. It's not the insurance company doing that. It's just that when the insurance company sees that code and that doctor puts that code down, then now that is diagnostic and they charge it a specific way based off of that code, right? It's just faster that way. And so what you see is that you can see having that so anytime that doctor now is saying that you need to come in on a different basis, or once we notice XYZ in your blood work or whatever, now we're trying to figure out what's going on with you. Usually everything after that is diagnostic. You still receive usually some portion of that visit. They'll still give you credit for as far as an in-network free charge. But usually there'll be charges and things like that afterwards that you will be subject to. So that's a very good point.
What do you mean in-network free charge? What does that mean?
So on your preventative, if you stay inside that network, so let's say that doctor visit, let's talk specifically and use the example of colonoscopy. In that colonoscopy situation, even though that doctor's going in and snipping out those polyps, the colonoscopy visit as a whole is still free. The surgical expense for those polyps is not, right? So even though it's subject to the deductible and it's going to be a cost and probably closer to $1,000, you're still getting that colonoscopy for free. So that's what I'm talking about. It's like a discount off of what they have done. Does that make sense?
Okay, I'm more relatable to the mammogram scenario than colonoscopy. So
okay. All right, same difference. So if it is a mammogram, right, and they notice something, usually the mammogram is going to be fee-free, but the diagnostic review of your information on that mammogram may not be. So even though you have a bill that you're going to have to pay at the end of it, you're still getting credit for the mammogram as a whole being free.
But you don't pay for it at the beginning. They tell you before you even get the test done, okay, you now have to come out of pocket paying $1,600 if you want to find out what this lump is.
Yeah, so the way they shouldn't be holding you hostage as far as you have to pay this in order for us to tell you that. So don't let them do that first off.
Pretty much that's kind of how it goes. And so it's like, well, you have a deductible, so you have to pay this first before we can give you treatment, or before we can do the diagnostics, or before we can do an ultrasound, you have to pay this.
Yep. Yeah, and and all doctors' offices are different about that, right? But you're exactly right, is that when you go in, but think about it this way, is that if you're looking at your bill after you get done with that mammogram, right, it should be multiple line items listing out. And this is the importance of EOBs as well, right? And this, I should have done a slide on this. I didn't even think about it till just now. But the way you utilize your health plan is that when you go in, you give them your card, right? You get credit for that. That doctor codes it. It's sent off to the insurance companies. Usually that doctor pre-files that claim or looks inside that system to see how your plan works. And it tells you whether you owe like a copay or whatever it is to that doctor. But nobody should ever be paying any hospital bills, any doctor bills, anything that you get in the mail. Just closing your eyes and writing a check for it, right? Is that you want to make sure that you have your doctor bill and what's called an EOB, or an explanation of benefits. It's that thing you get from the insurance company that says this is not a bill at the top of it, right? And what that should do is it should line out all the services, the date that those services were rendered, what was done in that doctor's office, and how much you should owe that potential doctor. So now in your situation where it's like a mammogram or something like that, what you should see is that mammogram line item there and then $0 next to it. And then any diagnostic services that came from that mammogram should be a separate line item that you're then paying for or subject to the deductible or whatever it may be. That's the way that works. Does that answer your question more directly?
Yeah. Yes.
Okay. Any other questions regarding any of that? any other questions regarding anything I've covered thus far? That's pretty much it for me. I'm not going to sit here and beat you guys over the head with too much insurance stuff. But if you guys have specific questions or one-off questions that you guys wanted to reach out to me, I'm happy to help. More importantly, if it's specific about you guys, one-on-one, like we said, we don't want everybody talking about, we don't want a massive bunch of HIPAA violations or anything like that flowing through the presentation here today. But if you guys have more specific questions, feel free.
I do have a specific question. So when it comes to insurance companies and, us individuals, so when you get a bill in the mail and, you see the adjustments that are made for insurance companies, it'll say like adjustments or what have you. But if the person didn't have insurance, they get a full bill. How is it that they can make an adjustment for an insurance company, but not do a deduction or make some kind of adjustment for someone that doesn't have insurance or doesn't have the money to cover all of those costs?
Yeah, that's a great question. So the way it works out is, so if anybody heard me when I was talking about it before, especially talking about the HSA plans, when I say you don't have a copay whenever you go to the doctor or anything like that, is that all of those things, those are those insurance discounts that I was talking about that you get. So when you go in, you can see that discounted rate is the rate that doctor and that insurance company, United, Blue Cross, whomever, and that's why these insurance companies hold the thing that they hold most dear is those negotiated fees, right? So they have their proprietary doctor network, and they love that whatever that tactical negotiation is between them. And I don't know if you remember this happens all the time, but like Memorial Hermann and Methodist were fighting last year at fourth quarter, somewhere around there, or Blue Cross and Kelsey-Seybold or whatever will be out of favor with each other. So what is essentially happening there is those hospital systems are not agreeing to the negotiated fees for services that those doctors are putting, or that those carriers are putting in front of them. So what you see happen there is when they are inside the network, and that's why it's important that you stay inside the network, is that you'll review that EOB. It tells you what the discounted rate is just by having the insurance. But some doctors, and this is more to your point, are charging people less if they don't have to run it through insurance, right? And so they give you a cash option as well. And it can kind of show you how broken down this entire process is when your cash option is cheaper than the insurance option. And that's where I tell people, just like on a discount prescription drug program, it works the exact same way. Is review. Sometimes if you were never going to go to that doctor probably for the rest of the year, or you're never going to hit that deductible or max out of pocket, if that cash option is cheaper, then operate outside your health insurance plan. Do what's in your best interest. But nonetheless, is always review those EOBs, see what was charged in there, and more importantly, see how it was coded. If it wasn't coded correctly, that's when you need to start with your doctor first, not the insurance company, and have them fix that code. And they can go back and retroactive to it. But you see that discount, and then it tells you, you may owe your provider XYZ number of dollars. That's based on where you're at in your deductible, which it should tell you down at the bottom of that. And you could review all that.
There's a question here. If you go to a specialist and they give you special take-home equipment and didn't tell you at the time of your visit, you will have a co-insurance and get an unexpected bill as a consumer, do you pay X even if the doctor's office didn't tell you about the co-insurance?
This is a great question. And this is what I'm talking about when I was speaking today about consumerism, right? Is that is what you described there is how most of us interact with our doctor. They just tell you to do this, that, or the other, you do it, and then you don't even question it. And then bills start coming in, and then you're like, wait, what just happened here? But that's why that dialogue with your doctor, whether they told you or not, isn't your doctor's problem, unfortunately, whatsoever, right? And so once you go home with that equipment, or you get that equipment or purchase that equipment, you're done. So that's why it's so crucial that those conversations start in that doctor's office. Just like I talked about with the generic drugs, just like I talked about, on the pharmacy stuff, is make sure you're having those conversations with your doctor. Hey doc, I'm on a high deductible health plan. What's this going to mean to me financially? Or is there a cheaper alternative to some equipment that you're aware of? Or maybe they know a discount program or something like that. So start with having that dialogue with your doctor to prevent what you just got done talking about from happening, because you're pretty much on the hook once that happens and you go home and you have that equipment in your house. Looks like we have another question.
B. Rosa has a question. She's got her hand up.
Hi, quick question. So I don't know, I don't want to use the word illegal, but is it possible, it might be illegal, of, let's say if I make an appointment to see a specialist and the specialist is asking, what insurance do I have? I give them the insurance, I go to the visit for me to later find out they don't accept the insurance. Why is the provider still seeing me if you already knew from jump, you don't accept my insurance?
Yep, because they like making money. That's why they're doing that.
There
But
you go. So is that
but
an
you're-
illegal tactic? Like, what do I do? Because it's just a waste of my time. I'm gonna end up having to repeat myself with a different provider or whatnot. You know what I mean? And not only does the insurance even let me know, sometimes Blue Cross Blue Shield, their insurance prime provider, is not so much updated. You know what I mean? So even though it says it network, they're not really a network. So it's a catch-22. What can I do to please help?
Yep, great question.
Thanks.
And it drives into you as a consumer, right? And how you're utilizing this stuff. So two things. I can tell you that if you have the date and all, I mean, that's the hard part, screenshots of like showing that that doctor was inside that network on Blue Cross's website or whatever it is, then you can challenge that claim. And I suggest that you do challenge that claim. Now, having said that, is that doctor is under zero obligation. Illegal, not illegal, doesn't matter. They're under zero obligation to clear with you and let you know. Now, morally, do I think it's a good idea to talk to a patient and tell them that they're in or out of the network? Yes, I do. But do those doctors do that? No. Most of the time they don't. It's incumbent on you as the policy holder to make sure that the people you're going to see are inside the network. So 2 steps to that process if you want to make sure that what you just got done describing doesn't happen to you again. Step number 1, go online and make sure. Step number 2, call that doctor and ask, and you can't ask, do you take? Remember, we're going to call our doctors and say, are you in the Aetna, Blue Cross, or whomever it is network, right? And they should have to answer that. But even if that doctor lies to you, let's say, they still can charge you whatever they want. So it's always incumbent on you as a consumer to go online and make Blue Cross prove that you consider this an in-network charge. I based it off of this. Now you guys need to honor that and make sure that they do. Now, but if you go, because that can change daily. I mean, doctors can drop in and out of networks. The days, remember, if you remember back in the old days, there were big, huge books of everybody inside the network, right? Those days are done because by the time they print those books, then half those doctors are not even inside that network anymore, right? So you always want to make sure you're going online with Blue Cross Blue Shield. And I know all these insurance companies in the state of Texas, they all have mobile phone apps. Utilize those mobile phone apps, download them on your smartphone, whatever it is, and make that your first step when you're utilizing care. Okay.
So what do you do when your doctor's office is listed in the network, but not all of the doctors that work in the office are actually in network? Because I've seen that happen too.
That's exactly right. Y'all are bringing up a ton of great points. You do always want to make sure that the doctor you're seeing is inside that network, and not just take for granted that every doctor that's inside that facility or whatever it is inside the network. That's a huge, huge point that you need to make. Lately, I've seen, and most of the time that they have been, and one of the things I'll also tell you guys when it comes to the radiologists, anesthesiologists, and pathologists and emergency room doctors, is that you're seeing, we have had a massive problem in the state of Texas with what's called balance billing, and those specific doctors never joining that network like I was discussing before. But I can tell you is that major legislation has been put forward and passed and approved, and the state of Texas is actually leading this legislation for the country as a whole moving forward. And that there's balance billing legislation that went through the state of Texas last session, I believe. Don't quote me on that, but somewhere around there, that says that if you're a doctor operating in a hospital system that is inside that insurance company's network, is that you have to be considered an in-network doctor and you cannot balance bill. Now, that's only for non-ERISA qualified plans, which I'm not going to get too deep into the weeds with you guys. It means some plans are, some plans aren't qualified or subject to that. But what I can tell you that the way we're seeing it utilized is because those doctors don't know whether your plan is or is not ERISA certified, right? Usually large groups, it doesn't affect employees of large companies, and it does affect, or it does help employees of small companies. But because those doctors that are trying to balance bill don't know that, So they just kind of universally balance bill everybody, or they universally treat everybody as in network now. It's kind of self-corrected it on those bigger non-ERISA plans. Doesn't mean the doctor can't do it. They are still allowed legally to do it. But most of our balance billing stuff should be getting corrected very, very soon if it hasn't already started to become that way.
There's, like right now, they're saying that a lot of your medical doctor charges or bills cannot go to your credit bureau. But I received a call from a couple of our community leaders saying that, no, let's just say Methodist charged you $5,000 for something, and you made an arrangement to pay a little bit. And I'm making sure I got this right. But eventually you missed a payment or something, and Methodist they sold that debt to a debt collector, and then they sent it to the credit bureau. Is that legal? Because it's still medical debt.
Yeah, so there's a couple things, and we're going to preface everything I'm saying that I'm not legally doing anything or saying anything, right? All the same stuff that you guys, all the headlines you guys gave at the beginning. So just keep this in mind. But it's always a good idea to engage in negotiations and conversations when you have those medical bills. A lot of times you can get them knocked down. That $8,000 bill I spoke about with my dad, he ended up paying, after negotiating with those doctors and hospitals, I think he ended up paying less than $1,000 for it, right? So you always want to engage in that dialogue with your doctor or hospital so that you're negotiating that down. But I can tell you this, when it comes to a tactic in that negotiation, what I suggest is you have your total amount that you're willing to spend or whatever you're willing to pay them right then and there, and say, hey, look, I'll either pay this bill in full right here, right now, if you agree to X number of dollars. But if not, it's going to be too expensive for me. And I'm going to pay you guys, $10 a month until the whole thing's paid off. As long as you're making a payment on that medical bill, they cannot go to collections on you, right? Doesn't matter how big, how small it is, right? They don't usually go to collections on you. Now, like you said, you miss one payment, whatever it is, you do, it gives you a razor's thin edge. But if you do that, then they can go to collections on you. And just like any normal collections agency, they sell that debt just like student loans do and all that same stuff. It's all the same, exact same type of way that credit card companies work. It's all the exact same debt, right? So hospital systems, it's not insurance companies that are doing it, just to make sure everybody's clear. Your insurance company should never send you a bill other than your premium every month, right? You're never paying anything through an insurance company. All they do is tell you how much you owe that provider. That's it. And so it's between you and the hospital systems, or you and the doctor, or whomever it is. But yes, you're exactly right.
Awesome. Okay.
So yes, medical debts can go to collections.
It can. Yes,
Yeah.
absolutely.
Mhm. Wow,
Okay.
this was a lot. My head is kind of like, what? I was at first starting to do some other stuff, and then I'm listening, and I'm like, yeah, let me put this away for a second. Yeah.
Because, we were told by legislation that medical bills cannot go into collections, but I guess it can't.
Yes, they can.
Yeah.
Yes, they can. So you want to make sure that you're staying diligent, you're staying on those. Yes, they can go to collection. Now, like I said, you can create a small payment plan and it'll never go to collections, and you just pay your $5 on your $30,000 medical bill or whatever, and you're just going to pay it for the rest of your life. So it won't go to collections and it won't hurt you. But like I said, it's a razor thin margin. If you just ignore the debt altogether, it 100% will end up collections, and it'll 100% affect your credit score.
Yeah. Now some creditors, like if you're going to apply for a house or apply for a car or something like that, they generally don't count medical debt against you when they're looking, to extend some kind of line of credit or something to you. But you can definitely go to collections for or get counted against your credit report for medical debt.
And while they may not count it, I guarantee you they see it and they're deciding and they're knowing what they're doing with it, and they know, what kind of liability you have. So always good to keep the ledger clean if you can help it.
Agree.
Okay. Any other questions?
We had a lot of great questions in here. I think you kind of went through and answered most of them that were in the chat already.
Yeah, I tried to do it because I wanted it to stay. It's really easy. And when it comes to insurance, you just go down a rabbit hole of, you know, of all kinds of different stuff. So I wanted to make sure that it was on the topics that we were discussing at the time. So
Question, there was a question, and Nia, correct me if I'm wrong. If someone is on Medicare and the regular Medicare, A and B, but they also have a side insurance, they tell us not to get out of the Medicare and go into
are you talking about a supplemental policy or an advantage plan?
supplemental.
So I'll give you a really high level view of that Medicare market. But basically, so you have your Part A, your Part B, which is right, the federal government takes care of, pays your hospitals, pays your doctors. And then you need, it doesn't pay everything though. So then you need a policy usually that will cover all the gaps. And that's where you have a supplement plan, right? And a supplement plan can be with Blue Cross Blue Shield, like AARP, which a lot of people get those cards. United Healthcare funds that AARP system. All that good. Humana has a huge Medicare system. So those are those supplement plans. And usually it means you can keep your doctors. It's a PPO open access type of network. And those cost money though. Those supplement plans cost money. But usually your like out-of-pocket expenses, your deductibles are super low. So even if you may be paying the same amount as you do at your employer, your spend if you have a medical expense or something like that is usually way less. And they should always talk to their insurance broker and analyze what's best for them in doing that. But then you also have what are called advantage plans. And the Medicare Advantage plans are the big ones, right, that a lot of people do and that you're seeing massive growth in. And the reason for that is they're free, right? So you're talking zero premium when it comes to an Advantage plan. But it's extremely important that you focus on what that network of doctors looks like in that Advantage plan, because you can't go outside of that. So a lot of people, when they get older, eventually get cancer, whatever it is. And if you like MD Anderson, you want to go to MD Anderson, you think MD Anderson's the greatest thing since sliced bread, you may not be able to do that based on the Advantage plan you picked 10 years ago, right? And then think about this, is that once you pick what your Advantage plan is, or once you pick what your Medicare plan is, on a lot of times, if you wanted to switch carriers or something like that, you would have to answer health questions, you would have to answer pre-qualify in order to do that. So it's extremely important you pick kind of like a really good company in a Medicare plan that's going to work for you early, because you can end up paying for it later on down the road. So it's extremely crucial.
Yeah, because a lot of, and I'm not saying a lot of those Advantage plans, but you need to know what also they cover. Because a lot of times, you know, specifically when you become a senior, there's some things that you're going to need, and some of those Advantage plans don't qualify you for those things. But if you stayed in Medicare, it would qualify you. And that's what we're coming up with. A lot of our seniors are calling us, say, wait a minute, I joined the Advantage plan, but now I have this issue and it doesn't cover me with this issue. So then they have to wait till December 31st to go back to Medicare, which it covers. So one of the most important things that they need to know is make sure if you're getting into an Advantage plan, make sure you know what they actually cover and what medications you take, what kind of procedures you have, because some of those Advantage plans don't cover those things. So just get educated.
Yeah, that's exactly right. And you touched on it, and we didn't even bring it up. But then you have the Part P, which is your drug program, when there's a donut hole involved in that, which means you get coverage in the beginning, and then you have a gap, and then you get coverage at the end. And so there's a whole different, we could do a whole 2-hour segment on just Medicare.
Actually, we are. Next Tuesday is the Medicare and Medicaid presentation. So we're going to get into all of that too. So there's a lot of folks that this is a lot of information, and it's a lot to consume in one session, which is why we're kind of breaking it down this month for, health insurance. Tomorrow we're doing the life insurance and living benefits, what those plans are and what that looks like and coverage for that. And then we're going to get into the Medicare and Medicaid and open enrollment next week as well.
And
so
if anybody who watches all the programs needs a job or something like that, you guys are going to be well versed and ready to go.
But you know what? The one thing that we always tell everyone, and it's so amazing, when you'll see a senior and their child, their older child sitting with them watching our virtual workshops, because they're all learning the process together and making sure that their parent understands, okay, did you understand this? This is what you're getting. This is what you're doing. And that's what's the most important thing about this whole, all the virtual workshops, is that we're all in it together and there's someone always there trying to assist the senior and making sure they're educated in the process.
Indeed. What happened to
Did
Ray? Did his picture go?
He's there.
I think we lost him for a second. 'Cause I see him on Facebook. He's frozen on Facebook. Oh, yep, I think we lost him for a second.
But
Okay.
that's why we're doing all these different virtual workshops on insurance, because there's different process for each one. Get educated and help your parents, help your aunts, uncles, all the seniors. You have a next door neighbor that's a senior and you know it's coming up. Make sure they're educated in the process, and you have someone that's reading all the jargon. Is it jargon? Jargon?
Jargon. The jargon.
What is
All of the hoopla. All the hoopla.
Because you know what? We have found a lot of seniors that went to the Advantage part and left Medicare, and now a lot of their medical issues that they had is not covered. So you need to make sure that whatever concerns you're going through medically, make sure that it is also covered in whatever Advantage plan you're going to, or whatever type of insurance you're going to.
Yeah, just make sure that you're having the conversations with your families or what have you, or even if I say this for everybody that you try to do work with or get involved with. If the person that you're doing business with doesn't want to take the time to answer your questions, that's probably not the person that you need to be doing business with. So if you're in, your insurance agent, your doctor's office, whomever should be available to answer whatever questions that it is that you guys have, to make sure that you're comfortable and you get a good understanding. Another reason why we wanted to give this information is so that you can make informed decisions about what it is that you want, what you need, what what to do, how the process works. We're not by any means expecting anybody to walk away ready to go get an insurance license or telling everybody about all the different plans or whatever that are available. But as you kind of go along the process, you'll know what questions to ask, or, oh, I remember him saying something like this, or that doesn't sound quite right, just so that you can kind of make sure that you're aware of what needs to be done and what the processes are. So we hope that you guys got all the information that you needed out of this session. Again, it is being recorded and it is live on our Facebook page so that you can go back to review it. We will be sending out a link to everyone to go back and view this session again. And you'll definitely have the opportunity to share it with other family members or coworkers or what have you that need to go back and hear this information about health insurance and health insurance basics. So
Hit me up before we go to another subject real quick. Just remember, when it comes to health insurance, you have that 1 year. So if your doctor or pharmacist is telling you, well, you don't, now that you've changed your insurance, you don't qualify for this, you don't qualify for that. Guess what? You can still go in and change it through the process. You'll just have to wait that whole year, December 31st. So don't just say, don't allow someone to say, well, you don't qualify because now you've changed insurance, and you just go year after year after year, and you need this medicine, or you need this procedure, and you're just sitting there saying, well, they told me I didn't qualify, so I can't do anything about it. No, you can't. You have that 1 year, every year, to change your plan every year. So take that time and don't miss it. Make sure you document what date it is, put it on your refrigerator, because I put everything, and my mother's put everything on their refrigerator, and that's how I remember. So if that's the type of thing that is important to you, don't just sit there and let it go by month or year by year, and you still don't qualify, because every year, December 31st, you make those changes, you can qualify again.
all right. With that being said, if we don't have any other questions, again, tomorrow we have the living benefits and life insurance presentation that's scheduled for tomorrow. On the 13th, we have the Medicare, Medicaid, and open enrollment presentation that's coming up. I think that's all that we have related to medical plans or what have you. But there are other presentations that a month of service does offer throughout the month. If you would just go to the website at nrcdc.org to get registered, it's got a complete list there. I will also be sending out the schedule along with the copy of the link of this presentation so that you guys can see everything that's coming up for the month of September. If there are any presentations that we don't currently offer that you guys may be interested in, please feel free to fill out the survey at the end of this session and let us know what it is that you'd like to have us provide for you. So we can't do what we do without getting your feedback and knowing what it is that you like or what you need. So we want to hear back from you. So thank you guys very much for joining us this afternoon. Again, we hope the information was beneficial to you, and we look forward to seeing you back at other month of service presentations in the future. So thank you guys for showing. Mr. Patel, thank you for coming. Miss Allen, thank you very much. Miss Lori, Miss Melody, thank you guys for coming back. Miss Ernest was on. I know she had to leave, but thank you guys for continuing to support a month of service. We definitely appreciate it. So you guys have a wonderful afternoon.
I seen you.
You all have a wonderful afternoon and continue to take care of yourself and stay safe.
Bye. Thanks, Lori.
Thank you. Right. Bye-bye.